Hello, and welcome to Jegher MD. And welcome to October. It is Breast Cancer Awareness Month. And I thought we'd kick off the month talking about hereditary breast cancer. Many of you have asked for me to do a video on this, and particularly because of our political season here in the US as well, where we're thinking about new appointments to the Supreme Court, I thought it would be a good topic because the Supreme Court has made some interesting rulings in terms of hereditary breast cancer. So what do you say? Let's get started. So we're going to talk today about hereditary breast cancer syndromes, your genes and your risk. And really, I want to highlight here that this is really about syndromes. It is not about only BRCA 1 and 2, which is what many people think of when they think of hereditary breast cancer. The other thing that I think is important is that for many people, they may not be aware that most people who get breast cancer do not have a family history. Most people who get breast cancer do not have a genetic mutation. In fact, having a family history and a genetic mutation are really rare. But if you have those, it does increase your risk. Now, you also may be asking yourself certain questions, like, my aunt was just diagnosed with breast cancer, but she's on my dad's side. Or my cousin Bob was just diagnosed with pancreatic cancer, but he's a guy and that's pancreatic cancer. What do these have to do with my risk of developing breast cancer? Well, I hope that we can answer some of those questions here today. For one thing, it's important that you understand that half your genes come from your mom and half your genes come from your dad. And those genes are designed to help you prevent you from getting cancer. So if you have a genetic mutation, whether they come from your mom's side or your dad's side, that influences your risk. So in the case where your aunt was diagnosed with breast cancer, but she's on your father's side, remember those genetic mutations that are carried on your dad's side have just the same risk for you in terms of your breast cancer development as any genetic mutations on your mom's side. They count just as much. The other thing that's important to think about is that we're not looking only at a family history of breast cancer. Indeed, many of these are in syndromes. Now, the syndrome that we are most familiar with is BRCA 1 and 2, which many people think is simply breast and ovarian cancer. And while that's true, it also includes pancreatic cancer and prostate cancer. So when you're thinking about your family history and you're talking to your doctor about your family history and your risk, it's really important that you include both sides of the family and all of the cancers that you can think of, and maybe even some non-cancers. We're going to get to that in a minute. When we think about hereditary breast cancer, as I mentioned, this is really only about 5 to 10% of all breast cancers. And many of these are related to BRCA 1 and 2 gene mutations. Now, BRCA 1 and 2 are tumor suppressor genes. That means that these are genes that we have in us that suppress the formation of tumors. In other words, they prevent us from getting cancer. So if you get a mutation in one of these genes, that increases your risk. These genes are located on chromosome 13 and 17 for the biology wonks out there, and you can see the loci here in this diagram. Mutations in BRCA 1 and 2 do confer up to an 85% lifetime risk of breast cancer and up to a 60% lifetime risk of ovarian cancer. But remember, we need to consider other genetic mutations as well when we think about hereditary breast cancer. These include things like PALB2, P53, PTEN, and a number of others. So when we think about these mutations, I really like this graph. Those of you who have taken my course, An Introduction to Breast Cancer on Coursera, have seen this before. And this is a graph which shows you the allelic frequency on the x-axis and relative risk on the y-axis. So up in the top left, you can see P53, BRCA 1 and 2, PTEN, CDH1, STK11. These are rare. However, when you get a mutation in one of these genes, you do have a higher relative risk of developing breast cancer. On the lower right, you have things like CASP8, AKP9, FGFR2, and so on. These are relatively common, but the risk that they confer in terms of breast cancer is quite low. And so you have all of the spectrum in between. It's unlikely that there are mutations that are very common that have a high relative risk that we haven't discovered yet. And the ones that are very rare, that have a low frequency of developing breast cancer, are likely difficult to find. So really, the ones that we think are the most discoverable are the ones in between those two lines. And we continue to discover newer and newer genetic mutations all the time. So just because you may have had genetic testing in the past and may have tested negative, doesn't mean that you would still test negative today, because we're finding more genetic mutations, which may explain some of your history. Now, if we think about BRCA1 and 2, which remember are the most common gene mutations that result in breast cancer, I've given you here a breakdown of the risk based on average population who test negative for BRCA1 and 2, and the risk conferred with a genetic mutation in one of those genes. So you can see that for breast cancer, across any age, there is a significantly higher risk of developing breast cancer if you have a BRCA1 or 2 gene mutation. Male breast cancer is another one to really think about. Now remember, even if you don't have a genetic mutation, men can still get breast cancer, and they account for about 1% of all breast cancers diagnosed. But if you have a BRCA1 or 2 gene mutation, you're at about a 7% likelihood of developing male breast cancer. And that's why men who develop breast cancer should be tested for BRCA1 and 2. BRCA1 and 2 also increases your risk of ovarian cancer. And you heard last month in my video with Elena Ratner, which I will link here, on ovarian cancer, that this is really a cancer that whispers. The symptoms are really pretty nonspecific. And that's another reason to really encourage people who have ovarian cancer to get tested for BRCA1 and 2, and for those who have breast cancer to think about their risk in terms of BRCA, because it can increase your risk of ovarian cancer. And as we'll talk about in another video on risk reduction, removing your ovaries may be able to reduce your risk of both breast and ovarian cancer. Now remember, it's not just women who are affected by BRCA1 and 2, and it's not just breast and ovarian cancer. There is a significantly increased risk of prostate cancer with BRCA1 and 2 gene mutation carriers, as well as pancreatic cancer. So make sure that you're really taking a full family history of all of these cancers to understand your risk. Now, in the past, there were a number of testing guidelines that really gave us some kind of guides as to who should get tested. Now, certainly if there's a known mutation in your family, other family members are at increased risk of carrying the same mutation. If you are diagnosed with breast cancer under the age of 45, some say under the age of 50, we know that breast cancer is a disease of aging, and so when you start to get young breast cancer, one wonders whether a genetic mutation might be at play. If you've got bilateral breast cancer, why are you getting cancer in both breasts? Especially if the first was under the age of 50, you want to be thinking about whether there could be some genetic mutation at play. Triple negative breast cancers under the age of 60. So these are cancers that are negative for estrogen receptor, progesterone receptor, or HER2. If you are Ashkenazi Jewish with breast cancer at any age, Ashkenazi Jewish people tend to hail from Eastern European descent and historically had intermarried. There are now 3 specific loci that have been identified in people of Ashkenazi Jewish descent, which we can now test for. And so this is why this had been a provision. Ovarian cancer, as I mentioned, at any age, male breast cancer, and then if you have clusters of pancreatic, breast, ovarian cancer. Now, there are other breast cancer syndromes as well. Li Fraumeni, which is a mutation in P53, which can increase your risk of breast cancer by 50 to 80% by the age of 45. This is also associated with sarcomas, acute leukemias, lymphomas, adrenocortical carcinomas. So these are cancers of the adrenal gland, which sits on top of your kidney, brain tumors. Cowden syndrome is caused by a mutation of PTEN. And this tends to be associated with hamartomas, which tend to be benign, as well as uterine cancer, thyroid disease, which could be benign, and macrocephaly, or simply having a big head. Yep, that's right. The genetic counselors will actually measure your head circumference as one of the factors that play into Cowden syndrome. And this does increase your risk of breast cancer by 20 to 50%. Now, there are others as well. Hereditary diffuse gastric cancer caused by a mutation in CDH1 also confers about a 39% lifetime risk of breast cancer. And the breast cancer in this specific mutation tends to be more of the lobular type as opposed to ductal carcinomas, which are the more common type of breast cancer. And finally, Peutz-Jeghers syndrome, which has a hyperpigmentation of the oral mucosa and GI polyps, some of which may be adenomatous, but many of which are hamartomatous and therefore benign. These are caused by a mutation in STK11, also increasing the risk of breast cancer by 32% by the age of 60. Now, there are other moderate penetrance genes that have been identified as well. PALB2, which was recently found, is a partner and localizer of BRCA2, hence the name. PALB2, along with ATM or ataxia telangiectasia mutation, both infer a twofold increase in your risk of breast cancer. CHEK2 is another one which is being seen more and more commonly these days, also confers about a 20 to 40% lifetime risk of breast cancer. Now, in the past, we would often test just for BRCA 1 and 2. And some of that had to do with the fact that Myriad Genetics had the patent for these genes. Now, this is where the Supreme Court comes in. The Supreme Court heard a case in which people argued that a company cannot own a natural phenomena like a gene. Myriad argued that it had the patent to that gene based on intellectual property that it had in developing these tests. The Supreme Court found in favor of overturning the patent, and almost immediately there was a plethora of companies offering genetic testing, not just for BRCA 1 and 2, but for a number of potential genes that increase cancer risk. This is called panel testing. Now, there are pros and cons of panel testing. On the pro side, it certainly is cost and time efficient to test multiple genes at the same time, especially if you come from a high-risk family. On the con side, you may find what are called VUSs, or variants of uncertain significance, that we really don't know what they mean. You may have mutations in genes that have less clinical data, so we're not really sure about the implications, although we may know that they're pathogenic, and mutations may not explain history. So for example, if you had a breast cancer and they did a panel and they found that you were positive for a mutation in CDH1, Remember, that's the genetic mutation for diffuse gastric cancer, but nobody in your family had gastric cancer. The question would then arise, well, do we take out your stomach prophylactically to prevent you from getting gastric cancer now that we know that you have a genetic mutation that puts you at risk? But then again, nobody in your family had that. So how real is it? And so this can cause a bit of a conundrum. So you can see here that there are pluses and minuses either way. Now, since that time, genetic testing has gotten far more cost efficient, such that you can now get genetic testing of panels of genes for as little as $250, even without insurance. And so the American Society of Breast Surgeons came up with a consensus guideline a couple of years ago on genetic testing for hereditary breast cancer. Historically, we had recommended that only genetic counselors really put through genetic testing. And the reason for this was to really try to help patients understand all of the various combinations and permutations of genes that could be affected, what test was optimal to order, what the meaning of the tests were, and so on. The new ASBS consensus guideline recommends that anyone, breast surgeons, genetic counselors, or other medical professionals knowledgeable in genetic testing can pursue this. And they recommend genetic testing not just for those meeting the criteria that I mentioned before, but really for all patients with a personal history of breast cancer, including patients who are elderly, who have no other family history. Now, remember what I said at the outset. The vast majority of these cancers are not genetic. The vast majority of people who get breast cancer will not have a family history. And yet, the ASBS recommended getting genetic testing on everybody. Now, you may be scratching your head wondering why that is. And their recommendation was really this. If we can offer genetic testing at a relatively low cost to everybody, there is a potential that we could find genetic mutations that would be relevant. Whereas if we keep the criteria very strict, we may miss people who have a genetic mutation who otherwise may have changed their management. Now, you can argue for or against in all cases, but these are the most recent guidelines out there from the American Society of Breast Surgeons. They also recommend genetic testing for patients without a personal history of breast cancer who meet NCCN guidelines. And even if people had been tested previously, they recommend updated testing. Why? Because new genes have been found. The other thing that has recently been identified is something called BART testing, or looking for large deletions. So instead of just looking for a spelling mistake, for example, where you might not find a spelling mistake, we now have tests that will look to see whether entire pages of the book were removed. So it's still having a mutation, but you may have missed it when you were looking just for a point mutation. There remain a number of commonly asked questions. Does insurance cover genetic testing? And if not, how much does it cost? Well, it really depends on your insurance. Oftentimes, it's good to talk to your doctor or a genetic counselor about this. Some insurance companies will only cover genetic testing if you go through a genetic counselor, despite the ASBS recommendations. But even if you don't have insurance, as I mentioned before, the cost has come down significantly, and there are a number of labs offering panel testing for as little as $250. If you test positive, what does this mean for your family? Well, if you have a genetic mutation, depending on where that mutation is, in which gene, and how that genetic mutation is passed on to family members, they are at increased risk. By how much? Depends on whether this is dominant or recessive. But still, they are at increased risk. So if you test positive, you may want to inform your family so that they can be tested for the same genetic mutation. What if you test negative? Does that mean that you're free and clear? Not quite. Remember that we're still working on finding newer and newer genetic mutations. And continuous discoveries continue to be made in terms of the relationship between environment and genetics. So if you have a very strong family history, but your genetics are negative, I would still exercise caution, because something has to explain that family history, and we simply might not be there yet in terms of the state of the science. What is a VUS and what do you do about it? So remember, this is a variant of uncertain significance, and many patients will look at this and think of it like a mutation. But remember, this is not a deleterious or a pathogenic mutation. That means that in all likelihood, it really won't increase your risk, but we just don't know yet. So the recommendations are, if you have a VUS, not to do anything, but keep in touch with your genetic counselors, because they will follow this data. And as that becomes updated, they'll be able to contact you if new data arise as to what the meaning of this variant of uncertain significance means to you. What happens next? Well, here we start talking about risk reduction, and there are a number of possibilities in terms of risk reduction. These all vary in terms of which genes are mutated and what risk is conferred by the genetic mutation, along with your personal values and risk tolerance. For breast cancer, there are a number of potential risk-reducing strategies, including chemo prevention, which really isn't chemo, and prophylactic surgery. We can talk about that in another video. But I'll leave you with this final thought. We continue to learn more and more about genetics and the impact that that has in terms of our overall health. There continue to be a plethora of genes and genetic mutations that are discovered, and we're starting to learn more and more about what this means for your overall health. It can get somewhat overwhelming and intimidating, and so if you have questions about this that weren't answered in this video, I hope that you'll talk to your doctor or your genetic counselor and advocate for yourself to make sure that your questions are answered. I hope that this video has been helpful for you. Please do like, share, and subscribe. If you'd like to see other videos, please leave me suggestions on content that you'd like covered. Until next time, this is Dr. Peutz-Jegher wishing you all a safe and healthy week.